everyone, we are the group C3 and we are going to report AIRWAY 1F, Advanced Life Support.
These are the course learning outcomes. After 5 hours of various online class activities, the Level 4 nursing students will be able to: number 1, to define the following terms: advanced life support, advanced cardiac life support for adults, pediatric advanced life support, advanced trauma life support, cardiac arrhythmias, myocardial infarction, cardiopulmonary resuscitation, defibrillation, and post-cardiac arrest care. Second objective is to give the purpose of advanced life support. Third is to identify indications and contraindications of performing ALS. Fourth is to differentiate BLS and ALS. Fifth is to cite common materials and equipment used in performing ALS. Sixth is to identify factors which may affect the performance of ALS. Seventh is to explain the scientific principles involved in performance of ALS. Eighth is to discuss medical emergency situations needing ALS. Ninth is to give the requirements or qualifications of an ALS provider. And tenth is to identify procedural guidelines in performing advanced life support. And last and 11th is to plan a webinar program focusing on advanced life support. To start, we have myself and Mr. Plaza Stephen Joshua for the definition of terms. Advanced life support. This refers to the medical procedures for sustaining life, including the advanced diagnosis and protocol-driven treatment of a patient in the field such as defibrillation, airway management, and administration of medications. Next is advanced cardiac life support for adults. This is a group of procedures and techniques that treat immediately life-threatening conditions, including cardiac arrest, shock, stroke, and trauma. Next is pediatric advanced life support. This refers to the assessment and support of pulmonary and circulatory function in the period before an arrest and during and after an arrest. Advanced trauma life support. This is a protocol for managing trauma victims and designed to maximize management in the first golden hours after a trauma and ensure an optimal long-term outcome. It is usually performed by a team, with one team member securing the airway and another inserting venous cannula and another exposing the patient. The team leader should constantly repeat the protocol in further assessments to stabilize the patient and plan for further management or definitive care. Next is cardiac arrhythmias. These are abnormalities in the rate, rhythm, or both of the heartbeat. It occurs when the electrical signals that coordinate heartbeats are not working correctly. These are examples of cardiac arrhythmias: bradyarrhythmias and tachyarrhythmias. For the bradyarrhythmias, it is a slow heart rate and irregular heart rhythm or slow heart rate that is pathologic. And with this, we have sinus bradycardia and AV block. With AV block, it has first degree, second degree, and third degree. For the tachyarrhythmias, it is a heart rhythm with a ventricular rate of 100 beats per minute or greater. With tachyarrhythmias, we have sinus tachycardia, supraventricular tachycardia, atrial flutter, ventricular tachycardia, polymorphic ventricular tachycardia, and with polymorphic ventricular tachycardia is torsades de pointes. So for the bradyarrhythmias, we have sinus bradycardia, a sinus rhythm with a resting heart rate of 60 beats per minute or less. And in the side of it is an ECG of the sinus bradycardia. And next is the AV block, which is a partial or complete interruption of impulse transmission from the atria to the ventricles. This is the first degree on the side, a picture of ECG on the first degree of AV block. which are all normal P waves are followed by QRS complexes, but the PR interval is longer than the normal, greater than 0.20 seconds. For the second degree, some normal P waves are followed by the QRS complexes, but some are not. And there are two types that exist, which is the Morbitz type 1 and Morbitz type 2. For the type 1, the PR interval progressively lengthens with each beat until the atrial impulse is not conducted and the QRS complex is dropped. The AV nodal conduction resumes with the next beat and the sequence is repeated. For the type 2, the PR interval remains constant. The beats are intermittently non-conducted and QRS complexes drop, usually in a repeating cycle of every third or fourth wave.
So this is the third type of AB block, the third degree. The heart block is complete. And this is a picture of an ECG strip of an AB block with a third degree. We also have tachyarrhythmias. The first one is sinus tachycardia, a regular cardiac rhythm in which the heart beats faster than normal and results in an increase in cardiac output. This is an ECG example of a sinus tachycardia. And then we also have supraventricular tachycardia. It is having an electropathologic substrate arising above the bundle of His and causing heart rates exceeding 100 beats per minute. This is an example of a supraventricular tachycardia. The third type of tachyarrhythmia is an atrial flutter, a cardiac arrhythmia characterized by atrial rates of 240 to 400 beats per minute, usually with some degree of atrioventricular node conduction block. For the most part, morbidity and mortality are due to complications of rate. This is the picture of an atrial flutter. And the fourth one, we have ventricular tachycardia. It is characterized as a wide complex QRS duration greater than 120 milliseconds, tachyarrhythmia at a heart rate greater than 100 beats per minute. This is an example of a ventricular tachycardia. The fifth tachyarrhythmia, we have polymorphic ventricular tachycardia, a malignant ventricular tachyarrhythmia with changing QRS pattern that will either terminate spontaneously or will deteriorate to ventricular fibrillation causing cardiac arrest. And then we also have Torsades de Pointes, is a type of polymorphic ventricular tachycardia characterized on electrocardiogram by oscillatory changes in amplitude of the QRS complexes around the isoelectric line. This is a picture of Torsades de Pointes. We also have myocardial infarction. It is also known as heart attack. It's the irreversible death, necrosis of heart muscle secondary to prolonged lack of oxygen supply. Cardiopulmonary resuscitation is a life-saving emergency procedure that involves breathing for the victim and applying external chest compression to make the heart pump. And defibrillation, the use of a carefully controlled electric shock administered either through a device on the exterior of the chest wall or directly to the exposed heart muscle to normalize the rhythm of the heart or restart it. We have post-cardiac arrest care, a critical component of advanced life support, the goal of which is to optimize systemic perfusion, restore metabolic homeostasis, and support organ system function to increase the likelihood of intact neurological survival of a patient after cardiac arrest.
Good day, everyone. I am Ms. Shanine Alexia Cordoves, and I will be the second reporter for this topic. I will be reporting CLO number 2, which is the purpose of advanced life support. So one purpose of advanced life support is it uses to provide urgent treatment to cardiac emergencies, stroke, myocardial infarction, and other life-threatening conditions. So what are life-threatening conditions? These include breathing emergencies, choking, heart attack, strokes, heavy bleeding, poisoning, and shock. So the second purpose is it is used to increase survival rates of sudden cardiac arrest or other emergencies by providing urgent treatment to cardiac emergencies such as cardiac arrest, stroke, myocardial infarction, and other conditions. According to the Heart Rhythm Society, sudden cardiac arrest is a leading cause of death in the United States, accounting for an estimated of 350,000 deaths each year. Symptoms of SCA may include irregular heartbeat, shortness of breath, loss of consciousness, sudden collapse or no pulse. Many of those who have suffered a cardiac arrest also report feelings of chest discomfort, faintness, and palpitations. Medical attention must be administered as soon as possible after the victim collapses. The chances for survival decrease 10% with every minute without intervention. Many SCAs occur outside of the hospital, which is why public access AEDs have the potential to help save the lives of countless loved ones struck by cardiac arrest. And lastly, it also aims to achieve the best possible outcome for individuals who are experiencing a life-threatening event.
So hi everyone, I am Mary Christine O. Estiva and I'm tasked to discuss and report the CLO number 3, which is the indications and the contraindications of performing the ALS or the Advanced Life Support. So first we're going to discuss the indications or the signs to when to perform the ALS or the Advanced Life Support. So if the patient has no breathing, no pulse, and whether he or she is unresponsive. And second is if the patient has a cardiac emergencies such as myocardial infarction, cardiac arrhythmias, and stroke, or any conditions that is related to cardiac. And third is the respiratory emergencies. So the example of respiratory emergencies if the patient has a airway obstruction, pneumothorax, and respiratory depression. And lastly, the last indicator for ALS is the patient is under in trauma emergencies. So what are the trauma or what are the examples of trauma emergencies? So if the client is in motor vehicular accidents, burns, or if a patient has a gunshot wounds. So next, we're going to discuss the contraindications. This time, we're going to discuss the scenarios that you're not going to perform the advanced life support to a certain person or to a patient. So first is if the patient has a DNAR order or has a do not resuscitate orders. So second is if the patient has any advance directive that indicates not to perform any life-saving procedures in cases of emergencies. So the third one is if the patient has also a ACLS termination of resuscitation. So the ACLS stands for Advanced Cardiovascular Life Support. So later on, I'm going to show you the chart that is being provided by the American Heart Association. So the fourth one is when the person lies dead with an obvious clinical signs of irreversible death. So there are signs of obvious and irreversible death, so such as decapitation if the patient has no head, and next is decomposition if there's a body decay, and postmortem lividity, postmortem rigidity, and burned patients who are beyond recognition. So lastly is when performing CPR puts the rescuer in danger of becoming physically injured. So next one. So this is the chart that is being published by the American Heart Association under in our advanced cardiovascular life support termination of resuscitation. So here we're going to see the first scenario, which is arrest not witness, no bystander CPR, no return of spontaneous circulation before transport of the patient, and no shock was delivered before transport. So there are two criteria. So first one is if all criteria are present, consider termination of resuscitation. So second is if any criteria are missing, continue resuscitation and transport. So remember that ACS termination of resuscitation are the contraindication of performing the advanced life saving. So that's it for the CLO number 3. So next reporter for CLO number 4 is Miss Faldo. That's all. Thank you.
Hello, good day everyone. My name is Miss Faalda and today I will be discussing to you CLO number 4, difference of basic life support and advanced life support. So let us begin with the basic life support as to its definition. It is a level of medical scale used to treat victims experiencing life-threatening illnesses or injuries until they can be given full medical care at a hospital. So basic life support, it requires knowledge and skills related to CPR, use of AEDs, and relieving airway obstructions. Basic life support providers can administer oxygen and provide extrication, immobilization, and bleeding control, and can also assist clients in taking their own medications. But they are not authorized to perform any invasive procedures and may only administer a few selected medications as prescribed by the physician. A BLS unit includes only 2 emergency medical technicians, and emergency medical technicians, paramedics, or even qualified bystanders can perform basic life support. While advanced life support, which is also referred to as advanced cardiac life support, is a set of life-saving protocols and skills that extend beyond basic life support. It is used to provide urgent treatment to cardiac emergencies such as cardiac arrest, stroke, myocardial infarction, and other conditions that needs immediate treatment. Advanced life support providers can perform more advanced skills than BLS, which includes intubation, needle thoracostomy, defibrillation, and cardiac pacing while administering a wide variety of pharmacotherapy including advanced cardiac life support medications. Therefore, they can perform invasive procedures and administer a wide array of medications. An ALS unit has at least one paramedic, and professionals qualified to provide advanced cardiac life support are trained and authorized to administer medication, perform injections, and conduct airway procedures prior to the arrival of the patient at an advanced care facility. It is one of the vital steps in the American Heart Association's chain of survival, which is a sequence of actions that can increase survival rates of sudden cardiac arrest and other emergencies. The 5 critical actions include immediate recognition of cardiac arrest and activation of the emergency response system. So this is the time that we'll be contacting emergency health team. Number 2, early high quality CPR with an emphasis on chest compressions. Number 3, rapid defibrillation or the activation of AED. Number 4, effective advanced life support. Number 5, integrated post-cardiac arrest care. And number 6, in addition, we have the recovery state. That's it for my part. Thank you and have a great day.
Good day, everyone. My name is Anna Dominic Gison, and today I will be discussing CLO number 5, which is the common materials in performing ALS. Let us now start first with the resources for management of respiratory emergencies. First, we have the bag mask ventilation. So it is a self-inflating bag that is attached to a non-rebreathing valve and then to a face mask that conforms to the soft tissues of the face. Then we have the two kinds. First, we have face masks. So, mask ventilation is a basic and quite possibly the most important airway management skill. It can be a bridge to definitive airway placement or a temporary rescue maneuver in patients with an unanticipated difficult airway. Next, we have the ventilation bag. It is used to deliver oxygen to a spontaneously rebreathing patient or the bag compressed to manually ventilate them via a mask or a tube. For the ventilation bag, we have the two kinds. First is the self-inflating. So, it is easy for beginner to use. It self-inflates, which can be used with room air if no oxygen is available. It is more forgiving of poor mask fit. Bag always refills and will not alert you to loss of mask fit. FIO, or fraction of inspired oxygen, is limited to a maximum of 60% unless reservoir is added and allowed to fill. Next, more difficult to feel the lung compliance of the patient. It also cannot feel the patient's respiratory effort, rate, or tidal volume. Lastly, it is more challenging to reliably deliver smaller tidal volumes. The next one is free flow. So it is more challenging for beginner use. It requires free flowing oxygen source. It cannot be used without it. It also requires good mask fit to properly ventilate. It will deflate with poor mask fit. Also, poor filling warns you of loss of mass seal, allowing for correction. FIO is always at 100%. It is also easy to feel lung compliance. Also easy to feel respiratory effort, rate, and tidal volume. Lastly, it is extremely fine control of tidal volume possible even with the tiny tidal volumes. Next, we have the suction devices. For the first one, we have the portable suction device. It generates negative pressure, which is channeled through a special type of plastic connecting tube called a single-use catheter. The negative pressure creates a vacuum effect that pulls any blood, mucus, or similar secretions out of the throat. Next, we have the bulb or syringe suction. Compression of the bulb creates a vacuum for gentle suction of small amounts of bodily drainage, such as oral and nasal secretions. Next, for the suction devices is the wall-mounted suctions. It is traditionally used in hospital settings, dental offices, and other places where patients are unlikely to need transport. Many hospitals position a wall-mounted suction unit in every patient room. Almost all ambulances have onboard suction built into the wall. Lastly, for the suction devices, we have the suction catheters. It is a catheter that is used to remove mucus and other secretions from the upper airway, trachea, and the main bronchi. For the next one, we have the oropharyngeal airway. It is a medical device called an airway adjunct used to maintain or open a patient's airway. It does this by preventing the tongue from covering the epiglottis, which could prevent the person from breathing. Next, we have the oxygen delivery systems. First, we have the low flow oxygen. So the low flow oxygen provide oxygen at flow rates that are lower than patients' inspiratory demands. Thus, when the total ventilation exceeds the capacity of the oxygen reservoir, room air is entrained. For the low flow oxygen, first we have the face mask. A simple face mask is usually used to deliver a low to moderate amount of oxygen. A simple mask contains holes on the sides to let exhaled air through and to prevent suffocation in case of a blockage. It can deliver around 40% to 60% oxygen at 60 to 10 ml per minute. Last, for the low flow oxygen, we have the nasal cannula. For the nasal cannula, it is a device used to deliver supplemental oxygen or increased airflow to a patient or a person in need of respiratory help. This device consists of lightweight tube, which on one end splits into two prongs, which are placed in the nostrils and from which a mixture of air and oxygen flows. Next, we have is the high flow oxygen. So high flow oxygen therapy delivers oxygen through nasal prongs at higher than normal flow rates of traditional oxygen therapy. This therapy is sometimes used for people who are in respiratory distress. First, we have the non-rebreather mask with reservoir. So, it is a device used in medicine to assist in the delivery of oxygen therapy. An RRB requires that the patient can breathe unassisted, but unlike low-flow nasal cannula, the NRB allows for the delivery of higher concentrations of oxygen. Last we have is the high-flow nasal cannula, an oxygen supply system capable of delivering up to 100% humidified and heated oxygen at a flow rate of up to 60 liters per minute. All settings are controlled independently, allowing for greater confidence in the delivery of supplemental oxygen, as well as better outcomes when used. The next common material we have is the nebulizer. So a nebulizer is a small machine that turns liquid medicine into a mist. You sit with the machine and breathe in through a connected mouthpiece. Next we have is the pulse oximeter. It is an oximeter that measures the proportion of oxygenated hemoglobin in the blood in pulsating vessels, especially the capillaries of the finger or ear. Then next, we have the endotracheal intubation. We have the two kinds, which is the first one is laryngoscope. It is a small device to look into your throat and larynx or the voice box. Next, we have the endotracheal tubes. It is a tube constructed of polyvinyl chloride that is placed between the vocal cords through the trachea. Next we have is the mechanical ventilator. So a mechanical ventilator is a machine that helps a patient breathe when they are having surgery or cannot breathe on their own due to a critical condition or illness. The patient is connected to the ventilator with a hollow tube that goes into their mouth and down into their main airway or trachea. Now let us move on to the common emergency drugs used in ALS. First we have is the epinephrine. So this drug produces an increase in blood sugar and increases glycogenolysis in the liver. Through its action on beta-adrenergic receptors, epinephrine leads to bronchial smooth muscle relaxation that helps to relieve bronchospasm, wheezing, and dyspnea that may occur during anaphylaxis. The next one we have is atropine. It is a prescription medicine used to treat the symptoms of low heart rate or bradycardia. It also reduces salivation and bronchial secretions before surgery or as an antidote for overdose of cholinergic drugs or mushroom poisoning. Atropine may be used alone or with other medications. For the next one, we have adenosine. It is a naturally occurring substance that relaxes and dilates blood vessels. Adenosine also affects the electrical activity of the heart. Adenosine is used to help restore normal heartbeats in people with certain heart rhythm disorders. Adenosine is also used during a stress test of the heart. The next one is amiodarone. It is a potent antiarrhythmic agent that is used to treat ventricular arrhythmias and atrial fibrillation. The drug prevents the recurrence of life-threatening ventricular arrhythmias and produces a modest reduction of sudden deaths in high-risk patients. So, for the last common emergency drugs, we have the procainamide. It is used to treat abnormal heart rhythms. It works by making your heart more resistant to abnormal activity. Lastly, we have the other common materials that is used in ALS. First, we have the manual cardiac defibrillator. It delivers the shock through paddles placed directly on the heart. Next, we have the intraosseous needle. It is used in procedure for obtaining access to the circulation in an emergency, including some cases of cardiac arrest. And that's it for my part in the report. Next, we have the Laurentes Darino May to continue.
Hello everyone, this is Zarina May Lorenza, and I will be discussing CLO number 6. Identify the factors which may affect the performance of ALS. With the first factor, we have the high number of professionals in the scenario. High volume of professionals in the scenario could create unnecessary competition among each other. Additionally, staffs may be confused as to who is going to assist the doctor. It also is recommended that there should only be one doctor and 4 nurses in the emergency department. Next, we have the lack of harmony. Teamwork and collaboration is vital in responding to emergency cases and especially in providing care to clients. Doctors, nurses, together with the other healthcare providers, should create a harmonious relationship when providing care to a client to avoid inflicting harm and in order to effectively deliver the care to the patient. Next is the stress of any member of staff. Stress leads to reduced productivity. It also contributes to decreased organizational performance and high error rate and poor quality of work. We also have the lack of material and or equipment failure. Materials and equipment are the important things in order to perform advanced life support. If one material or equipment fails to function, it would be impossible to deliver the care effectively. Additionally, equipment failure can lead to unnecessary harm to the client and staff. We also have the lack of familiarity with emergency trolleys. When performing advanced life support and other emergency procedures, familiarity with emergency kits and trolleys is very important as this will aid to hasten and smoothen the delivery of care. Lack of familiarity will impede the delivery of care, resulting in poor quality outcomes. And lastly, we have the presence of family members. During emergency response, it is important to only have the people that can help alleviate the situation. The presence of family members can distract the staff performing the care to the client and may worsen the situation since some family members tend to panic a lot. So that is all for the factors that can affect the performance of ALS. Again, we have the high number of professionals in the scenario, lack of harmony, stress of any member of the staff, lack of material and or equipment failure, lack of familiarity with emergency trolleys, and the presence of family members. Again, this is Zarina May Lorente, and thank you for listening.